Hi everyone. In this video, I would like to discuss some methodological aspects of the ischemia trial. The ischemia trial was a study designed to test whether routine invasive therapy compared with optimal medical therapy could reduce major adverse ischemic events in patients with stable coronary artery disease with moderate to severe ischemia in non-invasive testes. It was a parallel group design. Um, we had two groups, the invasive group and the optimal medical therapy group. Regarding the selection of the population, it was a multi-center study with 320 sites in about 37 countries. Um, the trial was randomized, so they used a block randomization model. The blocks varied in sizes, which allowed allocation concealment. Regarding the outcomes, the primary outcome was a composite outcome of death from cardiovascular causes, myocardial infarction, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. But actually, this was not the original primary outcome designed in 2012. The original primary outcome was a composite endpoint of cardiovascular death and non-fatal myocardial infarction. In a few minutes, I will tell you why this outcome has changed. For the secondary outcome, they used a composite endpoint of death from cardiovascular causes and myocardial infarction and angina-related quality of life. So for group comparisons, they used an intention to treat analysis. So it means that patients were analyzed accordingly to the initial allocation. It was really important to reduce bias. And here we have the point we should discuss. So for sample size calculation, they actually used data from previous studies. They estimated a reduction of 18% in primary outcome with a power of approximately 80%. This would result with a sample size of 5,000 patients approximately. For the primary outcome analysis, they use cumulative event probability using the Kaplan-Meier model. And to test the hypothesis, they used the Cox proportional hazards. They actually specified that if any assumptions for the test could not have been met, they would choose the strategy for non-parametrical tests. So here we can observe in this chart showing patient enrollment that initially they have more than 8,000 patients, but actually more than 3,000 patients were excluded, most of them because they were not eligible for the trial. So most of them, they had no severe or moderate ischemia, or they had lesions in left main coronary artery, which was an important exclusion criteria for this trial, or more than 1,000 patients actually did not have obstructive coronary artery disease. So they ended up with approximately 2,500 patients in each group. Well, Problems related to the sample size calculation. Um, in the beginning of the trial, actually, they started to realize that event rates were really smaller than expected, and also that exclusion rates were bigger than expected. So they had a problem and they should find a solution. Actually, the solution was already designed, already planned. They had a pre-specified change of plans in primary outcome. So in case the event rate was were too low, or they had more dropouts than expected, they decided to change the primary outcome, including more components to that composite endpoint. So they decided to include a hospitalization for cardiac arrest, unstable angina, or heart failure. Well, here we have the table 1 with the baseline characteristics of the patients, and we can observe that the characteristics are pretty similar between groups. And here we have the primary composite endpoint. We have the Kaplan-Meier analysis. We can observe that the curves are pretty similar. We have in the beginning, for the first year, it seems that invasive strategy is worse. This is related to myocardial infarctions related to the procedure. But after the second year, we can observe an apparent advantage of the invasive strategy. But actually, when we test the hypothesis using an adjusted Cox model analysis, so this is a Cox model with adjustments for the baseline characteristics, we can observe that the hazard ratio is about 0.9. The 95% confidence interval is from 0.8 to 1.08, and the p-value is 0.34, so we conclude that there is no difference between groups. Well, the most important lesson from this study is, in my opinion, having an alternative plan. So sometimes it's really hard to prevent how event rates will behave, and also estimate the dropouts. So we should have an alternative plan for that. In this case, the plan B was a pre-specified change of outcome. So that's it. See you soon. Bye bye.